Good evening, everybody. My name is Dr. Pamela Maragliano-Muniz. I'm a prosthodontist, and I'm here in Massachusetts, just a little bit north of Boston. So I know there's people from all over attending this webinar, and I'm very grateful for that. But it's very cold here, and I don't know about you, but I'm most certainly ready for spring. But I'm excited to be here tonight to talk to you about new advancements in Recaldent technology. I'm a prosthodontist, but I'm also a former dental hygienist. So I always like to pair restorative dentistry and preventive dentistry really together because in my opinion, you really can't have one without the other. So I love having opportunities like this to talk about prevention and also how it does benefit some of our restorative patients. So let's get started. I know that you have the opportunity to ask questions. I will hopefully be able to address some of the questions throughout the beginning portion of this webinar or throughout the webinar as we go, but I will leave time at the end and I will do my best to answer as many questions as I can. I also like to provide you with my email address at the end, so if I really don't get to your question, and I apologize for that in advance, you can always reach out to me if you need to get any more information about any of the slides I am presenting or the information that I'm talking about or anything for that matter. So without further ado, let's get started. First things first, I do like to thank GC America. They are the sponsor for this webinar, and so without them, I really wouldn't be here and wouldn't have the opportunity to speak with you this evening, so I'm always grateful for that, and I like to throw that out there up front. Also, I do have other teaching commitments. I teach at a local dental school, and I also do some work via my publishing company, Penwell Publishing. I work on the editorial board for them, and that means that I get to sample a lot of products, play with a lot of products in my private practice. I also write about them and I lecture about them. But despite all of that, there is no relationship whatsoever with what I do at Penwell or the teaching that I do in a dental school with what I'm talking with you about today. So I always like to just throw that out there and be upfront about that as well. And I also will say that for better or for worse, the clinical photos that you see during this webinar are mine. So I don't alter them in any way. I may straighten them or crop them, but I don't alter them to try to prove a point that isn't there naturally within the photograph. So I always like to point that out as well. I'm hoping as we have this hour together, and I know that this hour is going to fly by really quickly, I hope that by the end of it you really can understand and you can appreciate the benefits of Recaldent in some preventive products. And there are new technologies of Recaldent historically, and we'll talk about these, that Recaldent was present in various pastes that you'd have to apply to the tooth, and it would be sort of an extra step after usual oral hygiene practices. But nowadays there's a new brush-on paste that would replace toothpaste that does contain Recaldent, and it will also have the benefits of that added paste, and there's even more benefits than just the paste that's there. So I'm excited to talk about the differences there and the added features of this new paste. And I'm also going to talk with you about the various types of patients that can benefit from Recaldent technology and this type of toothpaste as well. Some of these patient populations might surprise you. I know most people think about Recaldent and they think about, okay, well, they'll help prevent tooth decay or help with patients who suffer from dentinal hypersensitivity, or maybe even patients where they have an early lesion or a white spot and you're hoping to repair it or stabilize it. And Recaldent is very important and instrumental for all of those things, but I'm hoping that you'll get to see today that we might have some surprises as to why Recaldent technology might be an excellent choice for your patients and for your practice. So first things first, we will talk about dental caries because we kind of have to when we're talking about Recaldent. But I'd like to differentiate the difference between dental caries versus a carious lesion. Imagine I can tell you a few months ago my washing machine had a leak and I didn't identify it because I didn't have water on my floor. Unfortunately, it's on an upper level of my house and I noticed some staining on the ceiling on one of my lower levels. As you can imagine, that's pretty disappointing. But if I just painted over that spot on my ceiling, I really didn't solve the problem, right? And you would imagine that that stain would come right back because I didn't fix the initial cause for the problem. I didn't fix the leak. Well, that's how I look at dental caries. We can look at a carious lesion and say, okay, I see this lesion, we must fill it, let's restore it, and so the patient can move on with their life. But if we don't treat the oral environment, or we don't treat the bacteria, the pH imbalances, or even facilitate mineral exchange, we might find that if we simply just fill a tooth, that we're really not addressing the disease of dental caries or the underlying problem. So I like to differentiate dental caries from a cavitated lesion, and when I refer to dental caries, I am not referring to simply just a hole in the tooth, if you will. So moving on, when we talk about dental caries or a cavity, we know that there's a lot of ways that we can identify them. So first things first, we can identify them radiographically, and sometimes when we find an early caries lesion, it might be something that we want to stabilize or reverse, but a cavity or a caries lesion, when they get to this point that they've addressed into they've extended into the DEJ, we know that we must get in there and restore those. Also for root surfaces aren't as mineralized as enamel, and we know that they're at a greater risk for developing caries lesions in a susceptible population. Our restorations, if a patient is suffering from dental caries or an oral imbalance, our restorations will not have the lifespan that we would like to have and the lifespan that our patients might be expecting. And finally, we can always expect that dental caries will easily form in a pit or fissure because anatomically it's a great place for bacteria to hide, and if patients aren't able to get in there and properly clean those spots, we know that bacteria can proliferate in that area. We know that bacteria, when it is in contact with a fermentable carbohydrate, will create an acid byproduct, and if this process continues and this cycle carries on in this direction, we know that a caries lesion is going to result. So I like to, again, reinforce that dental caries is really the imbalance within the oral environment, whether it's a bacterial imbalance, a pH imbalance, or an imbalance from the standpoint of mineral exchange versus a cavitated lesion, which is really, as far as I'm concerned, a symptom of the disease of dental caries. And I think it's important that we use the best materials and techniques that we can to restore these problems, but if we don't address the disease, these symptoms will persist and our restorations might not have the longevity that we strive to have. I also think that we really can't talk about preventing dental disease, or even Recaldent for that matter, if we don't talk about our good old friend saliva. So I'm not going to give you a full anatomy lesson here, but I think it's important to notice a few things. Number one, the parotid gland provides the most stimulated saliva, and so most of the time when we are measuring stimulated salivary flow or unstimulated salivary flow, that's really why we always reach into the area of the parotid gland for that reason. I think it's also important to note that the parotid gland is responsible for some electrolytes, also for sodium bicarbonate. Why is that important? Because saliva is instrumental from the standpoint of the rebound of oral pH after an acid insult. So these are all things that take place in nature. The submandibular gland is responsible for the most unstimulated salivary flow. Oftentimes, when we're taking those tests, we sometimes reach under the tongue, and therefore we're trying to get information coming from our submandibular gland. I also think it's interesting to note that our minor salivary glands, they're important as well, believe it or not. They obviously help lubricate the bolus and help with mastication and deglutition, but they also naturally contain and contribute fluoride. So imagine that our saliva is going to contain different elements that are going to naturally boost our oral pH or help with the rebound of our oral pH after an acid insult, which does take place after we eat or drink anything other than water. And we also have our minor salivary glands that are going to contribute to fluoride, and there's a remineralizing property within our saliva, and that takes place in nature. Our saliva is also important just from the standpoint of oral homeostasis. It keeps everything in balance. We know that specifically there are 5 protective functions of salivary flow. Lubrication, lubricating the bolus so that it's comfortable to be moved and manipulated around the oral cavity and so that deglutition is not painful. Also flushing and rinsing. The saliva is instrumental for rinsing carbohydrates and food debris and food particles and bacteria out of our embrasure areas. There's also a chemical aspect to saliva, and I will talk about that, I think either the next slide or the slide after that. There's also an antimicrobial component of saliva. Also, even though saliva is 99% water, that little bit of 1%, believe it or not, is extremely important from the standpoint of mineral exchange. Saliva is important for the maintenance of calcium, phosphate, fluoride, various immunoglobulins, buffering agents, etc. And so we really need saliva to help keep the oral cavity in homeostasis and keep the oral environment in balance. There's also components in the saliva that are extraordinarily important. Mucins are glycoproteins, for example. These specifically help to clear carbohydrates from the mouth and to protect against caries, aid in repair of oral soft tissues, specifically by modulating calcium channel activity. But mucins are important from the standpoint of flushing and from a repair standpoint. Also, proline-rich phosphoproteins, they inhibit the crystal growth of calcium phosphate. So where there's saliva that helps to flush bacteria away, it should help to reduce that crystalline growth. It's a protective and a reparative environment for dental enamel, which is important for maintaining the integrity or the health of the tooth. Also, immunoglobulins. I know I just mentioned those. There's 5 types of them: M, G, A, D, and E. And specifically in dentistry, we tend to be mostly concerned with IgA. Secretory IgA prevents bacteria and viruses from adhering to mucous membranes, and we know that IgA is really important, and it's seen in autoimmune diseases such as rheumatoid arthritis and lupus. We also are concerned about amylase and other enzymes in the saliva. If you don't have an adequate quality or quantity of saliva, we won't see digestion starting the same way as it would with somebody with an adequate quality and quantity of saliva. So amylase starts the digestion process and it breaks down foods, and digestion truly starts in the oral cavity. Let's talk about enzymes, for example. Enzymes are really important because peroxidase, for example, and you don't have to memorize every little enzyme that's in the oral cavity, but it's important to understand that enzymes play a role in antimicrobial action within the oral cavity. Peroxidase, for example, has bacteriostatic properties. It reacts with saliva, and it inhibits the ability of bacteria to fully metabolize glucose. So this enzyme in particular is bacteriostatic. Lactoperoxidase, it's a component of the acquired pellicle. So lactoperoxidase is pretty much everywhere, or it starts to reform on the surface of the enamel even immediately following a prophylaxis. It adheres to the hydroxyapatite, and it influences or changes the qualitative and quantitative characteristics of the bacteria within the dental plaque. It oxidizes inorganic and organic substances within hydrogen peroxide, and it's bactericidal for oral bacteria, reducing that number of bacteria, and as a result, the acidity of that bacteria. So when you think about enzymes or salivary enzymes, we know that there's a digestive property to it, also an antimicrobial property, bacteriostatic and bactericidal, and as a kind of an adjunct result, it also helps to limit the ability for bacteria to cause these acid side effects. We also have to talk about salivary proteins. Salivary proteins are extraordinarily important in the caries process because they control the status or maintain the supersaturation levels of calcium and phosphate as it relates to tooth structure and hydroxyapatite. They also prevent a rapid drop of pH, and they also aid in a quicker pH recovery. We're going to talk about pH in just a moment. And these salivary proteins also have bacteriostatic properties. So if you had these slides right in front of you and you had a pen on you, I would tell you to put a little star here next to histidine and staphyrin, because we're going to come back and kind of revisit the importance of salivary proteins and proteins stabilizing calcium and phosphate in the oral cavity. As you can imagine, though, without an adequate quantity or quality of saliva, and I like to differentiate the two as well, because somebody with xerostomia, they may not be aware that they're suffering from xerostomia, because they might feel like they have an adequate amount of saliva in their mouth. But the fact of the matter is, if they have a reduced quantity of saliva, they also have a reduced quality of saliva, meaning you might not be aware of the quantity, but you don't have the efficacy of the enzymes and the proteins and the various elements of saliva to keep teeth healthy. So without an adequate amount of saliva, you can imagine that mastication, swallowing are all going to be negatively impacted. Obviously, digestion, specifically because we don't have the clearing ability to move these food particles out of the oral cavity, and we don't have the enzymes to begin the digestion process. Also, immunity. As I said, we have immunoglobulins within the saliva, and if we don't have our immunoglobulins, we also have a reduced host response to various oral infections and general infections as well. As I mentioned, saliva is a key component for oral homeostasis, and it's important for maintaining the oral environment from the standpoint of bacteria, pH, mineral exchange, immunity, digestion, all of the different elements that saliva has and all of the functions that saliva has. Without the adequate amount of saliva, you can imagine that oral homeostasis, or the oral environment, will be imbalanced all around. Also, I'm going to talk about this again in a little bit more detail, but the buffering capacity of saliva. If every time we eat or drink something other than water, the pH, and water is a whole nother story, but for the most part water, basically the pH is going to drop down, but the enzymes and the proteins within our saliva are going to naturally help to buffer this oral pH and bring it back to neutral, generally speaking within 40 minutes, sometimes 30 minutes. That's if we have an adequate quantity or quality of saliva. If you can imagine, if again, without an adequate amount of saliva, we don't have the ability to remove bacteria, remove food debris, especially fermentable carbohydrates. We're just creating an area for bacteria to proliferate. And also, without our salivary enzymes, we lose that antimicrobial property of saliva. So you can imagine that if we don't have an adequate salivary flow, bacteria is going to thrive. Also, saliva is the primary mode in which calcium and phosphate is supersaturated in the oral cavity. Without saliva, we lose the ability to stabilize calcium and phosphate. We lose the natural fluoride that takes place in saliva and the natural calcium and phosphate as well. So without saliva, we really are susceptible to a lot of different oral infections, dental caries, even periodontal disease, and some other infections as well. Here's my pH slide I've been talking about, and this demonstrates the Stefan curve, which we all know from dental school or dental hygiene school, that every time you eat or drink something or have a snack or a sip of any type of beverage, our pH is going to dip down. Once the pH dips down below 5.5, that's when you start to see that bacteria take over and the dissolution of enamel. But thankfully, due to our saliva, our pH tends to bounce right back in about 30 to 40 minutes. Most of us, if we have an adequate salivary flow, we don't suffer from disease or dental disease or caries because of this curve here, because we have enough protective elements so that the shift doesn't shift towards disease. Now, if you have an inadequate quality or quantity of saliva, the problem here is that we lose that natural capacity to buffer oral pH in a timely fashion. And so with a reduced salivary flow, it might take a person 2 to 3 hours, believe it or not, for oral pH to neutralize and return back to baseline. So as one can imagine, this happens very commonly with our xerostomia patients, that oftentimes you catch them walking around with a beverage or possibly a lozenge or a candy or something to help them stimulate their salivary flow, but every time they're sipping their beverage or potentially their lozenge or their candy, you can imagine that their oral pH is just resetting itself to be in acidic level. And if they're sipping or snacking on these throughout the day, you can imagine that they're spending the majority of their day in a pH that's conducive to the breakdown of hard tissue structures. So that's really where we have to consider oral pH and the role of the saliva to buffer oral pH as well. And there's things that we can do to help that, but we'll get to that later. Finally, I think it's important to talk about different salivary tests that might be available. Now, there's lots of tests that are available, and I'm not here to tell you what's the best test or what test should you run out and go buy right now. I'm here really to tell you that there's different tests out there. They test different things, and depending on what your goals are in your practice, then you can decide which test may or may not be right for you and your patients. There are tests like this one here, Saliva Check Buffer, that tests stimulated and unstimulated salivary flow, resting oral pH, but there's plenty of tests out there that will test ATPase activity of specific bacteria. There's also tests out there that will quantify bacteria so that when you go back, you can hopefully see the levels of bacteria minimizing. But I think that salivary tests, for me at least, are something that I use when I really need more information. I can identify pretty quickly if a patient's suffering from xerostomia because their saliva might look different, it might appear different, or even if their medical history it shows that the patient's on a medication that's going to reduce salivary flow. I already know that salivary flow is going to be reduced. So I don't necessarily need a test to confirm that, but there are times when I have a hard time identifying exactly what's going on within a patient's oral cavity. And if that's the case, then I'll break out a test and I will see what I can find. I know I used a test like this once to show a patient that I believed he had acid reflux because he had a lot of acid wear in his mouth, and he refused to believe that that wear on the occlusal surfaces where the restorations look higher up on the occlusal plane than the tooth, he didn't believe that an acid could cause that. He thought it was truly from grinding. So I took a resting oral pH and turns out it was quite low. And that was something that motivated him to go get the care that he needed from a primary care standpoint. So I'll use tests like that to either help me prove a point, for lack of a better word, or for something to identify more information that I need. Now, as I mentioned, we talked about bacteria a little bit, we talked about pH. Now we have to talk about mineral exchange and how minerals are passed between the saliva and the teeth. And it's actually quite simple. Well, it's not that simple, but I'm going to simplify it for you tonight. It's basically a process of diffusion where a material is in an area of high concentration, it will diffuse across a gradient into an area of low concentration. Now, teeth are made of hydroxyapatite, fluoroapatite, calcium, phosphate, and it's important that we maintain the minerals within the teeth because there is that constant cycle. Every time our oral pH drops, the bacteria thrive a little bit. Acid is produced by this bacteria, but our oral pH tends to rebound right back up, and at that time minerals will enter back into the tooth. And it's important that this cycle maintains a balance, meaning the minerals that leave the teeth are met by the minerals that re-enter the tooth so that we don't see disease take place. The problem is if there are risk factors or different elements of the disease that are going to tip this cycle towards demineralization, demineralization will occur, it will get larger, larger, larger until we have a lesion that needs to be restored. But the important part of this factor is the rate limiting step of the available calcium and phosphate in the saliva, not just fluoride. So this here depicts really what I'm talking about. So we have teeth, we've got minerals that are hanging out in saliva. The tooth is impacted by acid, whether it's a beverage or a snack or anything like that. And then what will happen is the minerals will leave the teeth when the pH is low, bacteria will thrive, and what we need to do is we need to repair this demineralized area. Now, one thing I think that's really important to talk about is that, remember I mentioned that remin is a process of diffusion, so that what we try to do here with our products that we suggest to our patients is to create a situation where the saliva has an excess of minerals that are available to be taken up into the enamel. And remineralization occurs when these ions are at a neutral state. Calcium and phosphate are neutral when they're bound to a protein. Now, in nature, the protein that they're bound to are histidine and staphyrin. Remember, I mentioned that. I told you to put a star in your brain about that. So again, I'll come back to that again. But there's these various proteins, and they're also bound by an acidic residue. But if calcium and phosphate are not stabilized, basically what they try to do is they go around and try to find other ions to bond to. So calcium is all over the oral cavity. Imagine we've got calcium on the teeth, on the soft tissues. We also have calcium that's bound to a protein within the saliva. And what happens during remineralization is that fluoride comes in and acts as a catalyst for this reaction. Fluoride is actually attracted to the calcium, and then the calcium is then brought into the tooth. And so this is a natural process that occurs constantly, but we also try to help this process along a little bit. You might have had a family member or a grandmother tell you to have, say, milk or cheese after you have a meal to prevent cavities. But here is why. Because when milk and cheese come into contact with saliva, it's broken down and it's enzymatically modified into a protein, specifically a casein phosphopeptide or a milk-based protein. Now, calcium and phosphate, it's bound to a casein protein or a casein phosphopeptide. This will be present in supersaturated concentrations within the saliva and the dental plaque, which in the presence of acid or more calcium phosphate or protein clusters, these will become available to remineralize the tooth. Now, as I mentioned, and why am I mentioning milk versus our salivary proteins? Because casein is actually structurally similar to histidine and staphyrin. So if we had to come up with something to put in our patient's mouth to fortify their saliva, it's interesting that a casein phosphopeptide is what's closest, the closest mimic to nature that we can find, basically. So when we're considering reducing our patient's risk or managing the imbalance of the oral cavity from the standpoint of minerals, pH, and maintaining bacteria levels, first things first is we must identify and we have to reduce our patient's risk, carries risk factors. Now, unfortunately, just due to the nature of time, I don't have the ability to spend time to talk about this specifically, but I've done webinars before about that, so definitely check it out on Viva Learning if you need more information, or you can always email me. But what we want to do to manage the oral imbalance, or at least try to maintain health as good as possible, we have to reduce the impact of the oral bacteria, whether it means to just break up the biofilm, or sometimes we might consider oral probiotics or oral antimicrobials or things like that. But it really is something that we need to break up the biofilm and not allow the bacteria to take over. We also must encourage a more neutral pH or a quicker rebound to a neutral pH. And we also need to facilitate mineral exchange. Just like I said, we want lots of minerals in the saliva that are just waiting and are available to be taken up into the tooth, whether it is to restore that tooth or to remineralize or repair that tooth surface. Now, one way to reduce the oral impact of, the impact of oral bacteria is to identify the characteristics of that bacteria. Now, this is one of my favorite disclosing agents. I'm not sure if you're using a disclosing agent in your practice, but this disclosing agent is extremely interesting, and it's so much more advanced than a disclosing agent I certainly used in dental school and dental hygiene school. This is called Triplaque ID. This is a disclosing agent from GC America. But what's interesting about this plaque disclosing agent is it's used just like other disclosing agents. It's a gel. You paint it onto the tooth. You rinse the disclosing agent off of the tooth, but there's the potential for 3 different colors to come up. So it's important to educate your patients, just as when you use the red or whatever disclosing agent that you used in the past, it will show patients where plaque is, whereas this disclosing agent is going to identify whether if the plaque is old plaque, meaning it's plaque that's been sitting around the teeth for greater than 48 hours, pink plaque, which is plaque that's less than 48 hours, and then finally blue, which is acidogenic plaque. That's plaque that's going to potentially cause a cavity down the road, for example. This is a bacteria that has a pH that's less than 4.5. So this is what it looks like. So you can paint it on. This was painted on with a cotton swab. You can use a micro brush. Another thing you can do is put it in one of those little tiny oral syringes, and you can kind of syringe it onto the tooth. There's a lot of neat ways to do that. Rinse it off, and then you can take a look and see what type of plaque is here. Now you can see here on this in the center photo that there's some purple plaque, meaning it doesn't look like this person flossed in a while. There's also some pink plaque, so there's floss that's probably just missed by their toothbrush, or perhaps this is an end of the day appointment and they didn't brush before their appointment. But if you look over to the photo on your right, you can see this acidogenic plaque, this blue plaque. And this is the plaque that we have to think about and take a step back and say, wow, this is the plaque that's most likely going to cause cavities. Or we really need to maybe consider on a patient like this using an antimicrobial or an agent to help raise oral pH so this bacteria doesn't proliferate. So this is an excellent way to identify whether or not the patient needs a specific recommendation. It's also an excellent motivator, and I find that it's definitely something that helps me from the diagnostic standpoint understand what kind of bacteria is present in my patient's mouth without doing sophisticated tests. This is extremely quick, and it really doesn't take much time at all. Now, when we talk about oral bacteria, what are we going to do? First things first, we're going to provide oral hygiene instructions to disrupt the biofilm. On the patient that you just saw, you can see that, maybe flossing and brushing might just be the answer here. But if you were to disclose the patient and they presented with a significant amount of light blue plaque, then chances are we might have to consider an antimicrobial. And oftentimes when I use an antimicrobial, whether it's a rinse or an antimicrobial varnish, I oftentimes like to couple it with an oral probiotic because I'd like to reduce the insult of the negative or the karyogenic or pathogenic bacteria, but I also want to promote the proliferation and growth of the healthy bacteria. So there's oral probiotics that can be purchased over the counter and really, really easy to use and something that can be extremely impactful for your patient's oral cavity. We also might consider something that's a bacteriostatic agent, something like maybe even an adjunct like xylitol. But if you're going to consider xylitol for your high-risk patients, you definitely want to stay within 6 to 10 grams of xylitol per day, whether it's a gum, a rinse, or something like that. And then we might even consider, depending on how our patients present, a combination of these so that we can either reduce bacteria, promote good bacteria, maybe cause bacteriostatic, or obviously oral hygiene, which is usually one of those things that we encourage across the board. So to encourage a neutral pH, sometimes it just comes down to simple diet or nutritional counseling and changing patients' habits and maybe trying to reduce oral contact time or maybe changing from a sugary beverage or snack to something that's sugar-free or changing from an energy drink, which we know are extremely harmful to teeth, to maybe something like water or something like that during workouts. So diet, habit modification. There's also apps because we know a lot of people love technology and there's an app for everything. Believe it or not, there are apps to evaluate and keep an eye on oral pH. So there's one app in particular, it's called pH2OH, that you could basically use litmus paper. It has a color wheel. You can match up what the pH of the oral cavity is. You can keep track of it. As a patient, you can keep track of your own. Or as a healthcare provider, you have the opportunity to keep track of your patients, believe it or not, via this app. So it's interesting. So that might be something worth checking out. We could also consider pH increasing products. Now you could do something that's extremely accessible and extremely easy, something like baking soda, for example. Baking soda toothbrushing is fabulous. It's water soluble, it's extremely non-abrasive, it's very gentle, and it will bring your oral pH up really quickly. You can even take a little teaspoon of baking soda, pop it in a water bottle, and patients can rinse with that after sugary meals or snacks, or really any meal or snack, and that will help bring the pH back up very quickly. I also know that there's various sprays and other products out there that you can dispense in your practice to help bring oral pH up. But to be honest with you, baking soda is the quickest, easiest way to go. And then we can also consider products to improve salivary quality. And that means we want to fortify the saliva with the minerals that might have been lost via xerostomia-inducing medications or medical conditions or chemotherapy and radiation therapy, or somebody may just not have the appropriate amount of minerals in the saliva, and we want to fortify that. And to do that, the spirit of that is to promote mineral exchange. We want more minerals in the saliva so that they're always available and readily to be taken up into the tooth. And we also want to restore fluoride levels. And we also have to consider nature and the ratios in which they exist in nature. And we also want to have a nice balance between fluoride and calcium and phosphate. So that brings me to my friend here, Recaldent. Recaldent is fluoride, calcium, well, not fluoride. Recaldent is calcium, phosphate, that is bound to a casein protein. So it's calcium and phosphate and a protein, and there are formulations that are available to that contain fluoride. But I want to talk about specifically the function of Recaldent because it's got a lot of important functions that the saliva should have, basically. First things first, Recaldent has a synergistic property with fluoride. It promotes the incorporation of fluoride into the plaque and subsurface enamel, which has a greater benefit than used with fluoride acting alone. So as you can imagine, Recaldent is going to transform plaque from something that we consider generally pretty virulent or bacterial or acidic to something that can actually promote health. That's pretty exciting. Also, Recaldent will buffer plaque acid via this mechanism with fluoride. When you're using MI paste products or Recaldent-based products, MI paste alone, plaque levels are elevated for about 48 hours, and when using MI paste plus fluoride, which is MI paste plus, pH levels are elevated for 96 hours. So imagine somebody who has xerostomia or who does suffer from an acidic oral environment. Just by virtue of using Recaldent, they'll have a higher resting oral pH than they would otherwise. Also, because Recaldent contains fluoride, calcium, phosphate, and a protein, you can imagine that it's going to inhibit demineralization. It's also going to promote remineralization by creating a supersaturated concentration of these minerals in the saliva that are available to be taken up into the teeth when necessary. Also, it acts as a prebiotic. CPP-ACP, or Recaldent, suppresses the growth of strep mutans, and it also encourages the growth of beneficial bacteria. So this works as an oral prebiotic. So this is something that, again, we've got a lot of benefit of Recaldent from the standpoint of tweaking the consistency or the characteristics of dental plaque to become healthier. It's also going to suppress the growth of strep mutans. It has a buffering acid effect, and also obviously demin and remin. And so this is something that's really a win-win for pretty much every patient. Now, right now, or historically, these were the two products that we could share with our patients to promote remineralization and inhibit demineralization. They're basically MI products, MI paste or MI paste. They both contain Recaldent. The difference between these is that MI paste plus contains 900 parts per million fluoride. And this is a paste that does contain casein protein. So as I described, casein protein is structurally similar to histidine and staphyrin that takes place in saliva, but casein is a milk protein. So if you have a patient with a milk sugar allergy, for example, a lactose intolerance, this would be completely contraindicated with somebody who simply has a milk protein allergy. Lactose intolerance or a milk sugar problem, this is not a problem with this product. So specifically a milk protein allergy. Now we always, because there is calcium in there, and so if we have patients that have significant kidney issues and there's a concern about the amount of calcium that they could potentially ingest, say if they have end-stage renal disease or they're on kidney dialysis or they suffer from severe kidney stones, I would always check with a physician, make sure that it's safe, but for most of the population, this is extraordinarily safe. Now, the problem or the downside with this product is that, or at least the criticism that I've encountered, is that it requires an extra step, meaning you brush your teeth, you floss your teeth, and then you take the extra step by placing a little pea-sized amount of this paste onto your teeth and using this after traditional oral hygiene practices. Now, it doesn't seem like a big deal. However, we know it's hard to get our patients to floss, and so this extra step might be something that a patient might not be willing to do, or they're not going to have the compliance that they would have otherwise. So this is why I'm really here today, is to talk about some new technology and that there's a new MI paste or a new Recaldent in the Recaldent family, if you will. And this one here is called MI Paste 1. This one came out last year in 2017. This is a brush-on paste. This is a paste that can replace traditional toothpaste, and patients can brush with it as normal, and they can still get the benefits of having fluoride and Recaldent applied to their teeth. So this one has 1100 parts per million sodium fluoride, which is a little bit different from MI Paste Plus, but this is similar to what is commercially available with any over-the-counter toothpaste. As I said, it contains Recaldent. It also has a mild abrasive in it, just like all toothpastes have. The RDA for this paste is approximately 64, which is extraordinarily low. The other feature of this paste is that it contains potassium nitrate. So I know that MI Paste and MI Paste Plus are extraordinarily beneficial from the standpoint of dentinal hypersensitivity or reducing dentinal hypersensitivity, but this paste has the added feature of potassium nitrate. So this is extremely excellent for patients that have hypersensitivity. As I said, they've got similar benefits, well, added benefits to the traditional MI products, and this improves patients' compliance because it really just eliminates the extra step. So currently it's only available in a mint flavor, but the flavor is quite nice, it's pretty refreshing, and at least it eliminates the extra step. Now, I also, if we're going to talk about Recaldent, and this is a Recaldent lecture, we have to talk about fluoride varnishes that contain Recaldent. This varnish here contains 22,500 parts per million fluoride, so right on par with many other available fluoride varnishes. But this is the only varnish on the market that contains Recaldent. There's other varnishes that contain different formulations of calcium and phosphate, but to have calcium and phosphate to be bound and neutralized by a protein, that is what makes it readily available. And this fluoride is excellent for the initial uptake of fluoride, calcium, and phosphate into the teeth, and it also has very reliable substantivity, meaning the calcium and fluoride and phosphorus uptake that is taken into the tooth maintains itself at high levels over the course of several months. So this is a varnish that's extremely excellent, especially if you're going to be bringing Recaldent technology into your practice. This does still have the same issue with patients that have a milk protein allergy, but I ask my patients and I can tell you that milk protein allergies are extraordinarily low, but it does happen from time to time. So when that happens, I usually have another varnish on hand as well. Now, I'm really excited to talk about which patients that might benefit from Recaldent technology. So for starters, obviously we're talking about tooth decay and patients that have dental caries or oral imbalances or patients that suffer from xerostomia. And these patients absolutely positively would benefit from Recaldent technology because of all of the features that Recaldent offers. Now, I also like to talk about the repair of incipient lesions or early lesions. I found that we can stabilize lesions or sometimes even reverse lesions if we can get our patients to be compliant with risk management recommendations and also the incorporation of Recaldent into their oral hygiene practices. Patients that have an acidic oral environment or patients that suffer from acid reflux or various GI disorders, any type of Recaldent product is going to help boost their resting oral pH. So this is going to be helpful from the standpoint of their teeth and also their soft tissue structures as well. Now, I really would like to take a minute as we sort of finish up here to talk about cosmetic dentistry and even implant cases, because as I mentioned, MI Paste Plus or MI Paste 1 has a very low RDA. Now, I know that RDA has kind of really hit the presses a lot lately because of abrasivity of teeth and different toothpaste that run the gamut of different types of, that present with different RDAs. Well, a couple of things that are really important to talk about is the RDA scale was really intended to identify the toothpaste's ability to remove stain, and in doing so, whether or not it's going to be abrasive to dentin. And so we know that if a patient has perfectly healthy enamel, pretty much they can use any toothpaste and they'll be just fine. Now, as a prosthodontist or even as a hygienist in restorative practices, I can tell you that nowadays patients don't present with teeth that are just made of enamel or dentin or cementum, but there's a high population of patients that present with cosmetic bonding or restorative bonding or porcelain veneers or CAD/CAM restorations or PFM crowns or gold crowns for that matter, or onlays or inlays. Now, we have to also consider the abrasivity of the products that we're using, specifically products patients go home with, but also products that we use as prophylaxis pastes and things like that, because if you can imagine that a paste that could possibly wear away dentin, that a paste can, without a doubt, take the luster off of a composite or start to break, or some prophy paste can start to break down the cavo-surface margin between a composite and a tooth. And so sometimes when we see composites that have stained margins, we can actually start wondering is it something that occurred iatrogenically because of some of the products that we're using in our practices, the products that patients are going home to clean their teeth with. Now, excessively abrasive products can also take the luster off of CAD/CAM crowns, especially if you're doing CAD/CAM in your office and you're only providing a surface stain and glaze to that restoration. And even highly abrasive prophy paste can take the stain and eventually the glaze and eventually the stain off of our crowns, which could negatively impact the long-term aesthetics of our restorations. So when it comes to restorative patients, patients with lithium disilicate restorations or any type of zirconia or composite restorations, I believe that we should go less is more when it comes to abrasivity. Another feature, and an extremely important feature of this paste, is that it has a neutral pH. Believe it or not, there are only about 3 products on the market of all of the toothpaste that are available in the United States that are neutral at their pH is neutral. And so the pH is neutral for this paste, and there's a couple others that are out there. And how does that benefit our patients? You think, okay, well, a neutral paste, that's great. Well, let's talk about our implant patients. There's these 2 studies that I've noted here in the corner of this slide because they're really important. They provide important information about implants and specifically peri-implantitis. Both of these articles talk about one of the problems with peri-implantitis is if you sample the plaque in an area where peri-implantitis has taken place, it turns out that there's some titanium that is actually eroded or corroded off of the implant surface, and it's residing within that plaque. And okay, so how do implants corrode? Do implants corrode? Well, it turns out that it is possible for an implant to corrode, and the most common reason that an implant's going to corrode is inflammatory response, an acidic environment, whether it's due to strep mutans or an inflammation around the implant itself, acidic fluoride solutions, and this whole process needs a lot more research. But to be honest with you, knowing that anything acidic in the oral cavity could break down your titanium dioxide layer on the outer surface of your implant, the more neutral, the more gentle the products, the better. Now, I saw a question here about what is an RDA. An RDA is stands for the Relative Dentinal Abrasivity Index. So every toothpaste that's out there does have an RDA that's attached to it. And in general, they're safe for teeth, they're safe for enamel, but when we start talking about restorative material, sometimes abrasivity might be too abrasive out there. The other toothpaste that are available with a neutral pH, I'm now getting into the questions aspect of our presentation here, are I know Crest Pro Health specifically, the Clean Mint, and there's a Colgate product, and I think it's got clean in the name. It's called Clean Mint or Clean something. That one has a neutral pH as well, but MI Paste 1 has Recaldent, a neutral pH, fluoride, potassium phosphate. In my opinion, it really has it all. So there's a question, actually more of a statement here, but I have to agree with you, Stephanie, that all ortho and Invisalign patients should be given a mandatory tube of MI Paste 1. You know what? I really can't argue with you there. I think that ortho patients would absolutely benefit from Recaldent technology, and I also think that we also have to consider the retention system that we're using after orthodontics, because if we're using an Essex style retainer where our salivary flow might be limiting the contacts of the tooth, then Recaldent technology is really going to help with that as well. So I'm going to get here to some of the questions. Let me see what I have here. There's a question about, what about after teeth whitening? Recaldent is excellent after tooth whitening. It's actually great. You can use it before and after tooth whitening. If you have a patient that suffers from dentinal hypersensitivity, or they just in general have sensitive teeth, you can use Recaldent technology as a pre-treatment. Let them use it for a few weeks. They can do their whitening, and then immediately after get right back to it. It will help to rehydrate the teeth really, really nicely. There's a question, is this available by prescription? Well, It's just like other MI products that it has to be currently dispensed in a dental office. So you carry this product in your practice and then you're able to dispense it to your patients that need it the most. And it says, where is MI Paste 1 available for patients to purchase? As I said, again, it's in the practice. And basically, I really can't quote the cost for you because I know that a lot of the attendees here come from really all over the world, and I can't really quote those fees, but I do know that there's oftentimes different promotions and different things going on that makes the price a little bit more favorable. But if you are already familiar with MI Paste, the price is pretty much compatible as well. So let me see what else here. Um, So there's a question, as a prosthodontist, how would I prefer a hygienist polish crowns? Can one polish with this paste instead? You could polish with this paste. I like that there is at least an abrasivity of this paste, even though it is quite low. I do know of offices that polish with MI paste, but there is no abrasive in MI paste or MI paste plus, so you don't have any abrasive there. As far as polishing, now if we're polishing enamel or tooth structure, that's a little bit different. I still believe in using a fine or an extra fine type prophy paste. There are available pastes out there that are even more fine than prophy paste, and I think it's definitely worth investigating. So when it comes to my composite restorations, especially if they're a layered composite in the anterior, my lithium disilicate restorations, or any anterior aesthetic case, I'm going to suggest that my hygienist is using a rubber cup or a fine, even one of my polishing wheels that I use for my composites, and they can use composite polishing paste. They could use MI Paste 1, absolutely. And again, there are really, really, really fine prophy pastes out there that are definitely worth considering as well. There's a question here of safe for pregnant patients. It is safe for pregnant patients. I mean, if you pregnant patients brush with fluoride toothpaste, this has the same concept, except for we suggest that you don't rinse the paste off of your teeth. So after brushing and flossing, you can spit the paste out. I don't suggest eating, drinking, or rinsing for 30 minutes after. And this isn't a high concentration of fluoride. It's similar to what is available in over-the-counter toothpaste. So it's very safe for pregnant patients. Children, obviously, children, you have to be cautious as far as if they're trying, if they're not old enough to learn to not swallow the paste. I might consider MI Paste without fluoride over MI Paste 1 or MI Paste. There's a question about if the company sends samples to the dentist. To be honest with you, I don't know. You can always invite the company to come in, GC America, invite them to come in and discuss, maybe some sort of visit with your staff and, kind of some sort of educational lunch and learn or some kind of get together like that. And maybe if it's possible, if your local rep is willing to bring samples, that's always a treat and always wonderful. So definitely worth investigating, but I really can't comment on that really very well. So there's a question on, does this work on patients with pain? There is a mild abrasive in MI Paste 1. So, is it going to remove the roughest of stains? No. Just like most toothpaste won't unless they're highly abrasive. But again, if we're talking about just enamel and dentin of a tooth, then a toothpaste is safe, but if they come in with other risk factors that are going to contribute to the potential of them developing tooth decay or dental caries, then absolutely MI Paste 1 is by far the way to go. I completely agree there. So let me see. So there's a question about how does this compare to some of the other fluoride products out there? Well, I can tell you it's comparable in the sense that most fluoride products contain fluoride, but if there's no products out there that contain the casein phosphopeptide protein, and protein is going to stabilize calcium and phosphate and make it the most available to be taken up into saliva. There's other pastes out there that contain calcium and phosphate, but it doesn't have that same stabilizing ability as casein phosphopeptide has. Let me see what else here. Okay, there's a question about what oral prebiotic or probiotic do I recommend? I recommend a probiotic that's going to be something that's accessible to you and your patients. For me, I like Evora Plus. It's something that's available in my local pharmacies and those type of stores, and it's something that's readily available. It's a lozenge form, so it's something where at night after oral hygiene practices, they can then use this oral probiotic before they go to sleep. So that's the way I like to do it, but there's a lot of different probiotics out there. There's lollipops nowadays with xylitol and probiotics. So depending whatever delivery system that's going to work with your patient population, I say go with it. I think a probiotic couples very, very nicely with an antimicrobial. Now, I'm just about out of time, so I hope that this evening you found that Recaldent technology is beneficial to pretty much all patient populations. I really can't think of any that other than patients with milk allergies that this can't benefit from, and that the new toothpaste that contains Recaldent offers similar features but also added features than the traditional pastes out there, specifically eliminating that extra step. So if we have better compliance and our patients are getting their Recaldent, we know that they're going to be doing much, much better. And finally, as I said, when it comes down to dental caries, there's that imbalance of oral pH, bacteria, and mineral exchange, and Recaldent really helps from all aspects. So it's one of those products that really gets in there and will improve the oral environment and hopefully maintain oral balance, really with one product, which is pretty nice. So with that, I'm out of time. I know we kind of went over questions already, so I'm going to skip over that. But I just want to thank you for your time and your attention this evening. Again, I promised you my email address, so there it is. If you have any questions on how to use any of the products that I talked about today, you can easily go to GC America's website, and there are videos, and there's training, and there's education there for you as well. So I hope you found tonight as fun and rewarding as it was for me to talk to you, and I wish you all a pleasant evening. Thank you.